got a variety of short presentations coming up. First on the agenda is Andy Quinn.
So, as James said, my name's Andy Quinn. I'm one of the East Yorkshire anaesthetic trainees. When I started out writing this, I was planning to kind of talk about an audit that's been going on in a quality improvement project for many years in Hull. Kind of 15 years looking at the modes of anaesthesia that we use for C-sections and then later on conversions from regional to general. And it kind of metamorphosised into talking about sustaining change. Something that's been going on for 15 years doesn't just stay that way, and it obviously requires a lot of effort. And I think we talk a lot about how to commence changing, but keeping things going in the long run doesn't often get so much attention. I didn't kind of know all of this, but the kind of first interest came in Hull following a maternal death in not an emergency section, but a patient having a GA who sadly died. And this was the kind of time that things started and people looked at pushing doing a regional anaesthetic rather than a general anaesthetic. The problems in doing so, obviously you're dealing with a relatively small number of cases, you're dealing with patients who haven't necessarily stayed the same. I suspect most people would sit there and think, BMIs are probably increasing, maybe patient expectations are changing, and does the thing that worked 15 years ago still hold true now? Other things happen as well. I think most trainees I've spoken to would say that maybe they don't feel like they get the same exposure as perhaps people used to, and you rotate all the time. It's very hard to keep a workforce that's fully trained up when potentially they're rotating every few months or their time on the labour ward's quite slim. And the same goes for the non-anaesthetic staff as well. Kind of the midwives, I would say, is a bit more of a transient population. It also kicks back to who's in charge, and I think when leadership changes, maybe the unit loses its vision on where they're heading. So when I was looking at this, sorry, I've gone a little bit ahead, but obviously nothing's new, and I'm not the first person to think about this. The NHS sustainability model is about 10 years old or thereabouts, and gives a kind of framework for how to address the sustainability of something that you've endeavoured to do. It divides things up into 3 main groups and then subdivides bits to look into. Process is the first one, and probably the thing I kind of got drawn to. This first thing, benefits beyond patient care, I think is interesting. Human nature, I think, among healthcare workers, is we only ever try and do things that benefit patient care. But for something to be cemented and stick around, it needs to go more than that. And people will always aim for that bare minimum. But they'll do the things that make life easier. They'll do the things that make things more efficient. Getting kind of leadership on board is much easier if you can show that maybe there's cost savings in there, if there's other things that you can do beyond patients just being happy when they walk out the door. The credibility of the benefits you get from a process, and when we're kind of talking about this regional anaesthetic thing, there's a lot of other bits that feed into it. Epidural rates, kind of training techniques. There's a lot of things that I think you can draw in as to the success of this thing of how we do regional anaesthetic for a C-section relies on a lot of other things going on. And the credibility of the benefits, I think we kind of talked about it with the psychology lecture earlier, but I think everybody kind of leaves a nice regional section feeling a lot happier than when they've left a crash GA section that's never quite kind of calmed down and people feel they've got that cortisol running around. Adaptabilities are talking really about if you make this the default structure and the belief, will it withstand everything that rocks up into the obstetric unit? When you've got your anaesthetist in theatre doing a section and there's 2 epidurals waiting to be done, have you got that kind of resilience of your structure to maintain it? Also, is it something that's dependent on one person? If, you know, Dr. So-and-so, who's the person who pushes a particular thing left or something else happened, would things change? And possibly that's something that we see less with the trainees who rotate, but the leaders in the kind of clinical leaders in the department probably show that more as more noticeable in their absence. When I was kind of examining things in Hull, things that picked up, it wasn't immediately clear to me where these things were coming, but I think benefit beyond patient care was one. When I thought about these kind of things about time, discharge, time to discharge and this kind of thing, all impacted in on there. Monitoring progress is another thing. If you're going to do 15 years of a project, you're going to have a lot of data if you're looking for it, and streamlining that is a big part of it. Staff have kind of talked a little bit about, the main one here is behaviours. Do the people who are actually doing this job see that what they're doing now is the best way to do it? And another thing comes in with the senior leadership and the training. Has your new way of doing it become the old way? Do people still feel that they can challenge it and try and take some ownership and push it to be even better than it once was? Organisation, I'm not going to dwell on an awful lot, but it's a massive topic, isn't it, with an NHS organisation, and trying to get the board involved in what you're trying to change or trying to keep changing, or even just stay still, doesn't last. They don't tend to be very interested in what's going on, and so certainly in Hull everything was a clinically led push with agreement from the senior board. So just wrapping things up, obviously it's a very quick topic or quick talk on a big topic. There's a few things that I'd probably invite people to think about. All of the things that are going on in your department, these sustainability and change issues, think about the things that were done 5 years ago, 10 years ago. Are they still going on? Have you just got a laminated bit of paper stuck to a drug cupboard somewhere that says 2014 on it? Have a look at this model and see if you can apply that, or is there anything else that comes up with it? The other thing I'd say is with trainees, I'll take that as time. As much as keeping trainees skilled is difficult, they are your kind of fresh enthusiasm for a topic, and maybe they're the people to try and get